Good evening. Can everybody hear me okay? Sarah, can you hear? Sarah can hear. Okay, perfect. Good evening. Always the technical difficulties. Well, thank you so much for joining us tonight. My name is Alex Donovan. I'm one of the medical oncologists here at the Callaway Young Cancer Center at Valley View. I see all kinds of cancer here with my partner, Dr. Steve Mayer. We see, as community oncologists, we see all kinds of cancer, but breast cancer is certainly one of the most common. And for those who've been participating in our series thus far, we've learned a lot about benign breast disease. We've learned a lot about surgical options for breast disease in general, benign or cancerous. We've learned about mammograms. We've learned about plastic surgery and reconstruction. And so tonight I'd like to teach a little bit about the chemotherapy and hormone blockers that might come along with breast cancer and who needs what and why, because every breast cancer is different, and I'll teach you a little bit about that. I just wanted to remind people from the beginning that there's no verbal questions, but we will have time at the end to take questions, and so you can just submit questions in the Q&A down at the bottom of your screen. And at the end, for those who haven't had their questions answered, I can email you separately with that information. So with that, let's go ahead and get started. So I'd like to teach you about breast cancer and who needs chemotherapy and why. So for those of you who have ever been diagnosed with breast cancer, or who have had a friend or family member diagnosed, it's pretty overwhelming and it's scary from all different directions. And this is a very broad topic to cover in a 20-minute presentation. So I'm just going to touch on very superficial overview management of breast cancer, really focusing on early stage disease and what that means. So the treatment of breast cancer in general is very multidisciplinary. We almost always have surgery involved. That's really the only way to cure breast cancer, to cut it out completely, is for surgical intervention. And so we do that for stages 1, 2, and 3. And we'll go through staging in a minute. Everything else we talk about is to help reduce the risk of breast cancer from coming back. Stage 4 is a separate discussion, which we won't really cover tonight. So almost everybody with breast cancer needs surgery of some sorts to take out the primary tumor. The need for radiation really depends on the type of surgery that you undergo and the stage of disease. And you're going to learn a lot more from our radiation oncologist next month with next month's seminar. And so for today, I'll just mention that it really depends on the type of surgery, meaning if you have a lumpectomy, to just remove the tissue and do what we consider breast conserving therapy to preserve the breast tissue as much as we can. Anybody who undergoes a lumpectomy generally has radiation as well. And then if you have a mastectomy and remove all of the breast tissue, the need for radiation really depends on lymph nodes and staging. But again, you'll learn more next month with Dr. Rossi and Dr. Kropp. And then the role of systemic therapy, meaning something that kind of gets throughout your body to reduce the risk of breast cancer recurrence. That usually comes in the form of pills or IV chemotherapy, and that's what we'll talk about. And that's the role of a medical oncologist to help guide that treatment. And the treatment very much depends on the cellular markers involved with breast cancer. And that's why every breast cancer is different. So just briefly to touch on breast cancer staging, like most other cancers, we stage it stage 1 through 4, stage 1 meaning very early stage, and stage 4 meaning more advanced, has spread to other organs. And in general, we consider stage 4 disease metastatic breast cancer. meaning that unfortunately we can't usually cure it, and all of our treatments are palliative, that we aim to help prolong life and slow cancer spread, help alleviate cancer-related symptoms, and that's usually in the form of pills or chemotherapy. We normally don't do surgery and radiation in the setting of stage 4 disease. For stage 1 through 3, on the other hand, we do consider all of these early stage, and the goal of treatment is to cure the cancer. So for stage 1 is usually a small isolated tumor in the breast tissue. Stage 2 usually means that the primary tumor is a little bit bigger and might include some lymph nodes nearby. Stage 3 is when it's much larger, more extensive lymph node involvement. Cancer likes to break away and go to lymph nodes. That's the first place it goes. They're sort of the blood filtering system for our body. And cancer likes to break away and go to lymph nodes first, and they usually go to the ones in the axilla or the armpit. And so stage 3 is usually more significant lymph node involvement, and also might have some either skin or chest wall invasion. But all three stages, stage 1 through 3, are considered curable with aggressive treatment. And so we almost always do surgery, plus or minus radiation for most people, and then pills or chemotherapy for most people. But every breast cancer is different. And so that's why I really encourage people who've been diagnosed with breast cancer not to compare their breast cancer to everybody else, because the hormone receptors are very different, and the treatment is different depending on the stage and these receptors we look at. So try very hard not to compare yours to others. But these cellular markers we talk about really help us determine the behavior and the treatment for the breast cancer. So the most common receptors that we talk about, I hope you guys can see my cursor here. I'm not sure if you can. But we look at estrogen receptors. When we consider, you might hear something called hormone receptors, and that's speaking towards estrogen receptors and progesterone receptors. The most common and important one being the estrogen receptor. And then we also look at something called HER2. So with the estrogen receptors, here's an example on the left of a cancer cell, a breast cancer cell. And inside the cell, there's a little receptor called an estrogen receptor that basically feeds on estrogen coming in and binding to that receptor. And that tells that cell to divide and continue to divide in an uncontrolled fashion, which is what causes cancer and a mass to grow. And this is important for estrogen receptor positive breast cancers because we have treatments aimed to block estrogen to help cut off the food supply and essentially stop these cancer cells from growing. On the other hand, you might have also heard of something called a HER2 receptor, and this is very different from the hormone receptors. This is where this is a normal cell. It is normal to have some receptors on the cell, but in the case of breast cancer, there might be far too many HER2 receptors on the cell, and it sends signals into the cell to amplify and really divide this gene called the HER2 gene. And that is another signal to the breast cancer cells to just keep dividing in an uncontrolled fashion. And it's also important for us to know because we have treatments that can help block HER2 receptors. So in general, the treatment of breast cancer really very much depends on the type of breast cancer and these receptors. Of all breast cancers, the most common is a hormone receptor positive breast cancer. So about 70% of breast cancer cases are estrogen receptor positive, HER2 negative. And for these people, we're going to go through each of these in more detail. But for these individuals who have the most common type of breast cancer, we almost always recommend hormone blocking pills because of that estrogen receptor. Chemotherapy very much depends on some specialized tests that we'll also discuss. But really, the most common breast cancer is estrogen receptor positive, HER2 negative, and we almost always recommend hormone blocking pills. The two next most common types are HER2 positive. And so HER2 positive breast cancers come in two flavors, either estrogen receptor positive or estrogen receptor negative. But the most important part here is the HER2 positivity. And because of these receptors and a very specific medication aimed at HER2 receptors, we almost always recommend chemotherapy and HER2-directed therapy for a whole year of the HER2-directed therapy, and a shorter period of chemo. But pretty much anybody with a HER2 positive breast cancer will likely be receiving some form of IV chemotherapy and HER2-directed therapy. We only give the pills if they have estrogen receptor positivity. And then the third subtype here is called triple negative breast cancer. And that means all three of those receptors that we're looking at are negative. So the estrogen receptor, the progesterone receptor, and HER2 receptors are all negative. This occurs in about 10 to 15% of breast cancers. And in this case, we really don't have a targeted therapy, so we almost always recommend chemotherapy. And there isn't any benefit to the hormone blocking pills. So to talk about each of these in a little bit more detail, starting with the most common, estrogen receptor positive, HER2 negative breast cancer. The mainstay of treatment is hormone blocking pills. So we recommend these estrogen blocking medications that come in the form of pills. Another name for this is endocrine therapy. And there are some rare instances where it might not be necessary, but I would say in general, it is one tool we have to reduce the risk of breast cancer. And how it works is it's a daily pill, and it basically cuts off the food supply to any cells that have these estrogen receptors that are trying to divide. This will block the estrogen food supply to those cells. The goal is to continue these pills for about 5 to 10 years. And everybody's risk of breast cancer recurrence is different. Everybody has a risk of breast cancer coming back in the same breast, the opposite breast, or somewhere else in the body, which is less common. But these pills really reduce the risk by about 50%. And that level of risk just depends on the person. We use two primary types of hormone blocking pills. We use tamoxifen is generally used in the pre-menopausal women, and it's because of how it works when your ovaries are still actively releasing estrogen, versus aromatase inhibitors we use in postmenopausal women, and that's because the ovaries are no longer releasing estrogen. So they work a little bit different. I acknowledge that the way this estrogen is written on these little diagrams here is with an O. They're from an Australian website, but I thought it was a really good depiction of how these medications kind of work. So if you look at a normal breast cancer cell in the nucleus, which is sort of what carries the DNA and tells cells to divide, if you imagine an estrogen receptor, and the little yellow dot is an estrogen here, just a molecule of estrogen. If it binds to that receptor, it's going to tell that cell to turn on and divide, and tells that cell to grow. For tamoxifen, which we generally use in the premenopausal women, imagine this receptor is still there, but this is blocking the surface receptors, so estrogen really can't get in. And then in comparison, after menopause, when your ovaries are no longer releasing estrogen, we still have some hormones, or we have an enzyme called aromatase, and it comes in other tissues, mostly fat cells and muscle cells. Um, this is a normal enzyme we have that helps convert other hormones into estrogen. And so aromatase inhibitors basically block that enzyme to stop extra formation of estrogen, and overall just sort of decreases the amount of estrogen. So they work a little bit differently, but we can use both pills, whether somebody's premenopausal or postmenopausal, but to keep it simple, I'll just say that in general, that's how we divide it up. But we do recommend these pills for about 5 to 10 years, and that really reduces the risk of breast cancer recurrence. Chemotherapy, on the other hand, is very different compared to the other two types of breast cancer. The HER2 positive always gets chemo. Triple negative almost always gets chemo too. For estrogen receptor positive, HER2 negative breast cancers, chemotherapy really depends on characteristics about the breast cancer that tell us if it's more aggressive or not. For the more aggressive appearing breast cancers, chemotherapy can help, after surgery, kind of kill any cells that are nearby that are trying to grow, to reduce the risk of breast cancer. But for some of the less aggressive estrogen receptor breast cancers, which is the most common, most of them are slow growing, and we've found that there's not much benefit to chemotherapy over time. So we really only use chemotherapy in about 30% or less of ER positive, HER2 negative breast cancers. And chemotherapy very much depends on the stage of disease. Usually stage 2 and stage 3 breast cancers get chemo, not always, but for the most part. Stage 1 very much depends on this wonderful tool they've developed, I'd say in the last 10 to 15 years, called the Oncotype DX score. And what this is a molecular test of the tumor itself, analyzes 21 genes, and has been well validated to tell us how aggressive is this breast cancer and how helpful will chemotherapy be. So it generates, based off of each patient, a recurrence score. Hope you can see my cursor here. For an example, for a lower score is something less than 25. And here we have a recurrence score of 13. This is an example of what a report might look like. Then when you look down here, you see it very much depends on age, that for a low score, pretty much nobody benefits from chemotherapy, but especially postmenopausal women. Premenopausal women, it might depend on just how high this score is. There's a little bit of increasing benefit. I would say anybody with a recurrence score greater than 25 is generally receiving chemotherapy, that we've shown that chemotherapy can help reduce their risk of breast cancer from coming back. And it also generates a nice number here that just kind of puts things in perspective. It tells us on the right, there's really not much benefit to chemotherapy because of this low score. And that's really what this was designed for. But it also gives us a little hint as to how helpful the hormone blocking therapy is. So this middle number on this report, distant recurrence risk at 9 years, that tells us that within the next 9 years, what is the chance that this breast cancer is going to come back somewhere else in the body and be more serious with a pill, either an aromatase inhibitor or tamoxifen alone? And I told you that the hormone blockers decrease the risk of recurrence by about 50%. So how I kind of interpret this, and it's not perfect, but with the pills, this person might have a 4% recurrence, risk of recurrence within the next 9 years, versus if we did not take the pills, the risk would be upwards of 8 to 10%. And that's just an example of the lower risk we generally, for stage 1 breast cancers, we generally say, which is the most common, by the way. For stage 1 breast cancers, we say there's about an 18 to 20% chance that a breast cancer could come back in the same breast, the opposite breast. Much less likely somewhere else in the body. And it's this middle number here that's telling us when it's more likely to come back somewhere else in the body. Flip that to the other side here, you see that this person has a very high recurrence score. And I think this is a young patient example, not one of mine, taken from the internet. But we do see scores like this where they're quite high. Again, I said anything greater than 26, we would generally recommend chemotherapy. And you can see that the risk of recurrence somewhere else in the body is much, much higher. And that we do see a benefit to chemotherapy. So that's why, in general, anybody with a higher score, this molecular test gives us this ammo to say, yes, this person's at high risk of recurrence and chemotherapy can help reduce that risk. And the chemotherapies we're talking about are IV chemotherapies. But this is the tool that's very important and really helps us decide for those lower risk breast cancers. It gives us confidence that it's okay to proceed with hormone blockers alone and not do chemotherapy. And the only other thing I'll mention with the estrogen receptor positive, HER2 negative breast cancers is the sequencing of treatment. We almost always do surgery first. And then if we are going to do chemotherapy, we usually do it a period after surgery, but before radiation. And then the hormone blocking pills come after radiation. If we don't do chemotherapy, it's generally surgery, then radiation, and then the hormone blocking pills. So on to HER2 positive breast cancers. These are generally more aggressive. However, because of the targeted treatment, they have very, very good outcomes, meaning for early stage HER2 positive breast cancers, they are very curable if you receive the recommended treatment. And what that looks like is at least a whole year of HER2 directed therapy. We have IV therapies that bind directly to those HER2 receptors I mentioned. So we recommend a whole year of that. It's an IV treatment every 3 weeks. But then in the beginning, we also use chemotherapy. And that's because not only does the HER2 therapy bind to these little receptors and kind of tell the cells to stop dividing as much, but it, in a way, kind of opens doors for chemotherapy to get in to kill the cells more quickly. And so we almost always recommend some form of chemotherapy for a shorter period of time, 3 to 5 months, depending on the person. But then we recommend a whole year of IV. Herceptin is sort of the brand name you may have heard of, HER2 directed therapy. So it's IV therapy every 3 weeks. Chemotherapy depends, the intensity and type of chemotherapy very much depends on the age of the patient, their functional status, how healthy they are, and the stage of disease. So we have much more aggressive regimens that are every 3 weeks for about 6 rounds, versus more gentle regimens that might only have, 1 chemo and the Herceptin versus 4 medications getting in the other category. So we very much tailor this type of treatment to the person, the age, their stage, and how physically strong they are. But in general, anybody with a HER2 positive breast cancer, we will likely recommend IV treatment for at least a year. We only offer hormone blocking pills to those who have estrogen receptor positive disease. And then just to mention, we occasionally do chemotherapy before breast cancer surgery. Normally, the standard would be to do surgery, then chemotherapy, then radiation, and then continue the year of Herceptin. However, for very big tumors, these are so chemosensitive that they shrink really quickly in comparison to any other type of breast cancer. Because of the HER2 directed therapy, these shrink very quickly and respond very well to treatment. And so sometimes we use this treatment before surgery to really shrink the tumor and optimize the chance that somebody's going to have a really successful surgery, get good negative margins around, really get all the cancer cells out of the body. And it's pretty amazing, actually. These work so well that a lot of times, most of the time, and what we actually aim for is that by the time somebody gets to surgery, we cut it out. After chemo, they go to surgery, we cut it out. And under the microscope, pathologically, there's no evidence of breast cancer left. That is called a complete response. And it's actually pretty common and a goal when we use chemotherapy before surgery. We don't always need to do it, but I just wanted to mention that in case you've heard of that. And then last but not least, we have triple negative breast cancer. These are breast cancers that do not express any of those receptors. So on those cancer cells, there are other mechanisms telling the cell to divide. These generally behave more aggressively, but they don't have estrogen receptors, progesterone receptors, or HER2 receptors. So we really don't have good targeted treatments for them. But because they behave more aggressively, we always recommend chemotherapy. And that's generally for about 4 months or so, to reduce the risk of breast cancer from coming back. So it's still the same sequence, kind of surgery, chemotherapy, and then radiation. But then there are no hormone blocking pills moving forward to help these people. But I still want to mention that even though these behave more aggressively and are harder to treat, they're more likely to come back, especially with more advanced stages. If it's gone to lymph nodes and such, they're still curable. So just because somebody has a stage 1 or 2 triple negative breast cancer does not mean that it's absolutely going to come back. So that's really it for talking about breast cancer treatment in a nutshell. I spend an hour with each patient going through one part of that treatment for each patient. So that was a very superficial view of our approach to treatment. But I'm happy to take questions in a moment. I just wanted to speak towards our integrative therapies department. I think this really makes our cancer center and our hospital really unique compared to a lot of others. I came from Dartmouth Hitchcock out in New Hampshire, which has a lot of great services, but they were mostly volunteer based. Here we have a really incredible dedicated integrative therapies program that helps support holistic healing for all of our patients. Just speaking towards other, not as much natural medications, but natural approaches to help everybody healing on their journey and helping address side effects that are caused by the treatments we recommend. So we offer services such as acupuncture, massage, aromatherapy, a lot of psychologic counseling for the challenges that come with all of this. We have support groups, we have yoga and breathing classes, physical therapy, and we're continuing to work to really integrate more services for our patients. And we have very wonderful donors who have really helped support our integrative therapies department, so we can offer a lot of these services free or at very low cost for patients. We generally like to say that we really do offer them for free for most of our patients, which is really wonderful. So in summary, breast cancer treatment is multidisciplinary. It involves all of us, and we work very closely as a team. I think we have an incredible group here at Valley View. We're so grateful for our surgeons, our breast surgeons, Dr. Brew, plastic surgeon, Dr. Butterfield, but also our general surgeons, Dr. Ross and Dr. Nichols. as well as the radiation oncology team with Dr. Kropp and Dr. Rossi, who you'll learn from next month, and then myself and Dr. Mayer here in the medical oncology clinic. And we all work really closely together for every breast cancer patient. But the treatment is also very dependent on the cellular markers, as you've just learned. Surgery is the only curative way to help cure breast cancer. We can't cure it with these other treatments. Everything else we do is to reduce the chance of the breast cancer from coming back and to help support that true cure. And then just briefly mentioning those 3 types of breast cancers we talked about. The estrogen receptor positive, HER2 negative breast cancer is the most common. We almost always recommend hormone blocking pills and occasionally chemo. HER2 positive breast cancers always get 1 year of Herceptin with some chemo up front, and pills only if they're estrogen receptor positive. And triple negative breast cancers always get chemotherapy, but we don't have any hormone blocking pills to offer. So thank you so much for your patience tonight, and I hope you learned a little something. I want to give a special thanks to my amazing team in the medical oncology and radiation oncology department, and our surgeons here at Valley View, our integrative therapies department, Valley View Hospital, our gracious donors for helping support our patients so much, and to my family for supporting me and helping take care of our community. So I'm happy to answer any questions. Please drop them in the Q&A. And Sarah has a couple here for us. All right.
We'll just have you repeat them in case people can't hear me.
Sure.
But seems like hormones is a big topic because most of the questions are around hormones. Do I have to take them for the full 5 years? What are the side effects? And then these are all kind of lumped together. Why not just remove your ovaries and avoid having to take the hormones?
Oh my goodness, all good questions. So first question, this was a multi-layered question involving a lot of other questions that you guys submitted. First question is, do I really need to take the hormone blocking therapy for the full 5 years? And that, in general, yes, that is where our data comes from, that we really studied it, and that you got the most benefit by taking the pills for 5 years. There is some data that there is continued protection really up to 10 years, but it kind of plateaus off after 7 years. So we continue to have a risk benefit conversation with patients depending on how well they're tolerating the treatment or not. But generally, yes, we recommend 5 years. Everything comes with a grain of salt, and taking some of it upfront especially is better than not taking any, I would say. You know, in the world of cancer, where we see everything, it's very rare that we have something to help reduce the risk of a cancer. And so in my mind, you know, we do what we can. We're always going to recommend our tools that we can use to help reduce the chance. But, you know, we also have to weigh the importance of quality of life and how people are feeling. And so it's a continued discussion as to whether or not the risks of continuation outweigh the benefit, you know, if the benefits outweigh the risks. And the second part of that question was aimed at side effects of the hormone blocking pills. And oh man, this is a conversation we have multiple times every day. And I do think there are a lot of myths about it because some people have side effects, some people don't. We often hear more from people who do have side effects. So about 50% of people have side effects on hormone blocking pills. They're a little bit different for the tamoxifen versus the aromatase inhibitors, but I would say most common side effects would be hot flashes, maybe a little fatigue, but really not that much. I would say hot flashes are the biggest. Sometimes joint pain, but it's pretty noticeable, and that's reversible. If we try it and stop therapy, it should go away. There are some more rare, serious side effects of tamoxifen, including a very low risk of blood clots and uterine cancer. And so that's why we want to be careful and monitor closely. In terms of the aromatase inhibitors, the more longer term the only kind of longer term side effect that we worry about more so is bone density. It can weaken bone density, but it's by a very small amount over the 5 years that you're on it. And so even people who already have, and we monitor every 2 years, but even for people who have a little bit of bone weakening, it's okay to continue to strengthen the bones and do this treatment at the same time. And then there are more side effects, but we won't go into all of them. But I would say those are the main ones. And again, only 50% of people have side effects, and they might be mild and tolerable. 50% don't have side effects. And then the last question was if it makes sense to remove the ovaries. And so for premenopausal women, we actually do talk about that as a way to decrease estrogen production. And that's more so in BRCA mutation carriers who are at higher risk of ovarian cancers. We do use ovarian suppression methods either surgically or with some medication injections to suppress the ovaries. If the ovaries are still releasing estrogen, however, I will say you still have this enzyme that converts the other hormones into estrogen. So we still recommend some form of hormone blocking pills, even if we do take the ovaries out. Yeah, great questions. Any other questions?
No, they were all lumped around there, but if
Okay.
you have more and you send them in, we will get an email and we can start a dialogue with you that way.
Okay, perfect. So I don't know if you heard that. I think that was the bulk of the questions for now. I do see a typed one on just somebody asked about mammoprints and some other molecular testing. Aside from the oncotype that I mentioned, there are some other molecular tools that are available to us now. This person mentioned mammoprint and the breast cancer index. And these are sort of new tools we have. We're starting to use them. Every institution is sort of different depending on who has clinical trial access. Those are the ones who are usually starting to use those tools more. So we haven't used them quite as much. We're starting to use things like mammoprints more, but they're just other molecular tools that we're learning about to help guide our decision-making on things like hormone blockers and chemotherapy. So I think they're on the horizon. We haven't used them a lot here quite yet, but I think they'll be coming soon. And always okay to ask your provider about that. So if anybody else has any additional questions, you'll get an emailed response. And if you could fill out the survey after the presentation, when you get the email, that would be wonderful. And let us know about any other topics you'd like covered. A link to the recording will also be sent out tomorrow, and feel free to share it with anybody who might be interested. And a reminder that our next event will be Wednesday, February 15th at 6 p.m. And that will be with our radiation oncologists, Dr. Rossi, and our brand new radiation oncologist here at Valley View, Lauren Kropp. A really wonderful team, and they'll be discussing their role in the breast cancer journey. Thank you again so much for taking the time and supporting us all. Hope to see you out in the community, but not in our clinic. And if we do, I promise you're in good hands. All right. Good night, everybody.